Morning. First talk will be on the basis of Graft Hostel Immunology. Dr. Anjana Karunakaran from Chaitanya Eye Hospital, Trivandrum, will be rendering the talk. It is a surgical procedure where the deceased cornea is replaced by a donated corneal tissue. When the entire cornea is replaced, it is called penetrating keratoplasty. When only a part is replaced, it is called lamellar keratoplasty. So these are the different types of lamellar and penetrating keratoplasty. Lamellar keratoplasty is again divided into anterior lamellar and posterior lamellar keratoplasty, and the details of which would be dealt with in the subsequent talks. In anterior lamellar keratoplasty, we can see the anterior part of the cornea is replaced with the donor tissue. So this can be again divided into superficial anterior lamellar keratoplasty, where the dissection depth is less than 1/3, that is 160 microns. It's done in superficial corneal dystrophies like Lees buckler, granular lattice dystrophy. In deep anterior lamellar keratoplasty, dissection depth is greater than 1/3. It is done in deeper scars in keratoconus, pellucid marginal degeneration, etc. Anterior lamellar keratoplasty can be manual, automated or hemi-automated. As the name suggests, in manual dissection of both donor and host cornea will be done. In automated, it will be automated dissection. Hemi-automated, automated dissection of donor cornea and manual dissection of host cornea will be done. Now the advantages is that it is a non-penetrating surgery, so there is lower risk of endothelial rejection, there is better globe integrity and lesser astigmatism. But technically the disadvantages are that it is more demanding and poor post-op vision as compared to penetrating keratoplasty due to interface complications. Coming on to posterior lamellar keratoplasty, this can be of different types: deep lamellar endothelial keratoplasty, Descemet stripping endothelial keratoplasty, Descemet stripping automated endothelial keratoplasty, Descemet's membrane endothelial keratoplasty. So this is basically replacement of the deeper posterior layers of the cornea. So the procedures will be dealt with in the subsequent talks. So I am just going on to the advantages and disadvantages. The advantage is that it has a faster and predictable visual recovery. There is lesser suture-related complications. Ocular surface is unaltered, and like anterior lamella, it has a better globe integrity. Theoretically, there is lesser chance of graft rejection. But disadvantages is that there is chances of posterior lenticular dislocation, which is technically demanding, and there is endothelial cell loss. So the goals of keratoplasty: optical is to give the best possible visual acuity, therapeutic is to program or voluntary eye donation. So there is no minimum age limit in India, and we can harvest from infants to old adults tissue from the donor. Now it can be harvested as corneoscleral button, or we can do whole globe enucleation. Nowadays corneoscleral button is becoming more popular. Now what are the criteria for ideal cornea preservation method? It should maintain the endothelial viability. It should maintain a clear thin cornea during preservation. It should allow unlimited preservation time and provide cost effectiveness. It should ensure sterility, allow transportation of the donor tissue, offers technical simplicity, and provides suitable tissue for lamellar keratoplasty, epikeratoplasty, or penetrating keratoplasty. Now this table is the grading of the donor tissue based on the Descemet's fold, corneal thickening, stromal haze, specular clown. We can grade the corneas from excellent, that is A+ grade, to not fit for surgery, B, a minus grade. Coming on to high-risk corneal grafting. Now the the collaborative corneal transplantation study defined high-risk keratoplasty in those which recipient has 2 or more quadrants of deep stromal vascularization or history of previous graft infection rejection. Now the types can be endothelial rejection, which is most common, chronic stromal rejection, hyperacute rejection, or epithelial rejections. So the symptoms and signs are blurring of vision, redness, pain, photophobia. There will be limbal injection. There will be reaction as indicated by aqueous cells. Keratic precipitates in the graft can be viral recurrence, KP is present over the host as well as graft. That is what we have to differentiate. And endothelial rejection line, Kadal's line may be seen, along with graft edema. So coming on to management of the graft rejection, mainstay is early recognition and topical corticosteroid. In non-endothelial rejection, we can use topical corticosteroids. In endothelial rejection, we add intravenous methylprednisolone or dexamethasone along with topical corticosteroids, and corneal pachymetry can be used to see the decrease in corneal stromal edema. So, thank you.